I'm a thoracic oncologist, so I care most about lung cancer, but I think probably the most exciting data for me is outside of lung cancer is the daraxonrasib data in pancreatic cancer showing a very large overall survival benefit. Why do I say I care about that as a thoracic oncologist? Because we have KRAS mutations in lung cancer as well. So as proof of principle for targeting non-G12C KRAS mutations, which is about 60% of KRAS in non-small cell lung cancer, this is still really exciting data for us in the thoracic world as well. So I think that's the most exciting out there. Obviously, it's very exciting for the patients and the providers who treat and have pancreatic cancer as well, but it's also exciting for lung cancer. In the lung cancer specific world, other data that I'm really interested in seeing are more data on KRAS G12D inhibitors. We've seen a bunch of abstracts on that are to be presented at this ASCO, as well as a couple of abstracts on KRAS G12C that's specific with lung. One of those is the Crescendo 170, the proof of principle study in combination with pembrolizumab. Clearly, it depends exactly on how we think about this question. I think the easiest answer is just anything that's not KRAS G12C, because we don't have anything approved for that population. So KRAS G12D, which is about 15% of KRAS mutations, about 5% of non-small cell lung cancer, similar in size to MET exon 14 or EGFR exon 20 insertions. So we need drugs for those patients. And so we do have a couple of KRAS G12D drugs now entering the clinic, which is exciting. Beyond that, all of our KRAS therapies, the ones that are approved and the ones that are emerging, they all work, but most of them don't seem to work as long as targeted therapies for other subsets of non-small cell lung cancer, so EGFR, ALK, RET, RAS. There might be trivial explanations for this, like a lot of those patients are never smokers with very genomically simple tumors, and KRAS tumors might be a little bit more complex, have a higher rate of smoking. But I don't know that that's a sufficient explanation. And from a patient perspective, what we need is better therapies and better regimens for all of those patients regardless. Still today, the only approved medicines that we have are for KRAS G12C, and a large percentage of those patients, if not almost all of them, will have some history of smoking. The G12C mutation is a smoking-related mutation, and so we know both from subset analyses of patients with KRAS G12C and from in larger trials and just overall from a biological perspective, these patients do respond to immunotherapy. And since immunotherapy has the best chance in lung cancer for long-term disease control, we're still using immunotherapy first line for all of these patients. That said, some of the data that's emerging of combining with immunotherapy with G12C inhibitors when they're combinable looks quite exciting. There are first-line clinical trials now with G12C inhibitors, and if those are not available at your center, they might be of interest to patients. Again, some of this is more with the newer generation of medicines like daraxonrasib and maybe adagrasib, where we're seeing response rates in the 70 to 80% in combination with pembrolizumab in the first line. After that, adagrasib and sotorasib are available. Patients can get them in the community. They're not that hard medicines to give. And so then the other time where I'm frequently seeing patients is after progression on sotorasib or adagrasib. So they've exhausted chemo and immunotherapy, they've exhausted sotorasib and adagrasib. We are starting to see clinical trials from Revolution Medicines with their G12C inhibitor, from some other companies with their G12C inhibitors post-progression on another G12C inhibitor, and I'll be very excited to see what those results are in the next few years. So that's a good time also to refer.